Good. Okay, welcome to our Truth Health Tuesdays. Tonight we're talking about heart attacks, and we're going to lay down some stupid myths. Okay, now what's tough is, the myth is, today, it's part of the infrastructure. It's kind of like vaccines. It's part of the infrastructure. There's a huge amount of money behind it. Now, this is the theory. And the theory is simple, easy to understand, that you got a heart, it requires blood, cholesterol is really bad. Well, actually, you got bad cholesterol and you got good cholesterol. We got drugs for both of those, okay? And it's going to clog the arteries because your heart is too damn stupid to understand that it needs the arteries open. And you're just defective. Maybe it's genes. It has nothing to do with gene expression. Okay, it could be genetic. Okay, the arteries get clogged. But don't worry. We can put a balloon in there and blow up the clog. We can put a wire cage in the artery to open it up. We can give you drugs to thin the blood. Of course, all of those have side effects. And then at the worst, we can go in and do bypasses where we're actually going to take a vein out of the leg, split open the chest, go around, we're going to bypass the clog, and then we're going to close up the chest, and you'll be saved by modern medicine. Okay, so your body is defective. Okay, we're talking 1 in 3 Americans are going to have heart disease. Now, if we did the same correlation with antelopes or buffalo or geese, that 30% of them had heart problems, and we're going in to do little bypasses on the geese and, you know, little angioplasties and little stents, you'd think that was stupid, right? I hope you would think that was stupid. Okay, good. So this is the theory, okay, about clogs and arteries. Now, the tough part is this is huge in the infrastructure of our medical system now. Every hospital is a cardiac ward. Every hospital is going to be able to do a stress test or a chemical stress test. They're going to be able to shove dye into your heart, and they're going to be able to diagnose a clog. Okay? It's wrong. Okay, their diagnostic procedures are ineffective and wrong. So when we look at this, it was questioned because it seems too simple. But you got to figure out where does cholesterol come from? 80% is produced by our body. Does cholesterol clog arteries? No. Well, I don't know. Let's work with the medical thinking. Okay, they say it does. When they're doing a blood test, are they drawing the blood out of the artery or the vein? The vein. Well, how come cholesterol doesn't clog the veins? If it's going to clog stuff, wouldn't it clog the smaller arteries? So people would be walking around with like black fingers and toes, right? Mm-hmm. Okay, so that theory doesn't really hold water. So when we start thinking back in the history books, I start looking, and I find this study out of Heidelberg, Germany in the 70s, and they did autopsies on people that died of heart attacks. And they actually looked for blockages, okay? And they found only 20% had blockages sufficient to have caused a heart attack. That means 80% didn't. So you get something that's on a theory. Remember, it's not fact that the artery's clogged. It's not fact that you go in there with a balloon or a stent or bypass that you're helping the person. That's not fact. That's all theory. But it's taught to you over and over and over and over again. Who was it? He was a brilliant orator, but he was insane. He said, if a lie is told long enough and loud enough, people will eventually believe it. Hitler, yeah. Okay, now another study, now this was done in 1974, Heidelberg, 20% of the cases were found. A study done in 2004, they found only 41%, so less than half of the cases. Now remember, this is the infrastructure of most hospitals. This is what's running the business, okay? So you don't want to really question this. So I like this. I had to put, this is the title of the article. The idiopathogenesis of coronary heart disease, a hierarchical theory based on morphology. So it's trying to find out the problems, the pathogenesis, what actually started it. And it's not holding to the theory. Now this is, figure for about 2 decades now, I've been looking at angiograms. Okay, and what they'll do is They'll go in, they'll stick dye, and it'll illuminate, you'll see the dye go through in the heart, and they'll take a picture of it. And it never made sense to me when they said, oh yeah, see the clog? See the clog? And I'd look at something like this and I'd see a volume there, a compression area, and then the volume there. Now, is blood static or does it flow? So you're looking at a dynamic flowing structure. So if you have a clog, does it make sense that you should have the same volume on the other side of the clog, or do you think there would be reduced volume on the other side of the clog? Now I'm just talking about common sense, okay, which is obviously missing, okay, in this type of procedure, because when you look at it, it doesn't make sense. Now, through more advanced arteriograms, what they're seeing is that this clog there's always a secondary circulation. Your body's smarter and more adaptive than what we thought. If an artery gets clogged, the body will actually regrow. It's called an angiogenesis, where you can actually regenerate new arteries, okay, to adapt to that clog. So there's secondary and tertiary blood supply to the heart. And when you're looking at this, there's a really good video called Eating, where a medical doctor actually had a heart attack and found out his arteries were occluded. He was unaware that the real cause, but he went on a plant-based diet and cleaned his arteries. So what do we know? In the actual studies where they're opening up cadavers to see if the clogged artery is the problem, we're talking, in 74 they found 20%, in 2004 they found 40%, so that means 60% of the time there's something else, if even that is the cause. Okay, does that make sense? So we have to look at something other than clogged arteries, because obviously it doesn't make sense when you have a clog and you see the same volume on the other side. Okay. Now, does anyone know how they would do a stress test on a person? Yeah, well, a treadmill. Yeah, what if you have a knee problem? They do what's called a chemical stress test, and this is more popular. Now, I have a patient who's actually going to have that done, and I said, I really don't recommend you do it because it's foolish. So imagine you're sitting in a lazy boy recliner. They give you a drug to stimulate your sympathetics. Your heart rate starts to go. You're sitting in here and your arms are shaking. This is a chemical stress test. Do you think that's going to give a normal or abnormal function of the heart? Not in the medical world, okay, because they're just wanting to increase and see what kind of your body's going to adapt. But this is a chemical stressor, so it's completely abnormal. Then they inject the dye in it, and then if they see any kind of a clog, oh, you're lucky you came in. It's 50, 70, 80, 90% occluded. But now, let's go in and check it a little bit more. Now, this is acute, unstable angina or chest pain. So that means it just happened. Now, they actually changed the definition of heart attacks. You see, before the 1990s, when catheterization, and catheterization is actually putting a balloon, okay, and that's called angioplasty, where the balloon goes on this little wire and then it inflates and it opens up, forces the artery open. There's another one called a stent, where you get a wire cage in there and that forces the artery open. And if those don't work, then you take the vein out of the leg and you bypass it. Well, before 1990s, to be diagnosed with a heart attack, you had to have 3 different criteria. You had to have the typical heart complaints, okay? Felt like an elephant was sitting on my chest. I have massive chest pain. I have chest pain, jaw pain, and left arm pain. You had to have some of those type of symptoms, okay? Then you had to go in and get a change in the electrocardiogram, the ECG, okay? So chest pain, some type of heart symptoms, change in that. And then they would look for certain blood values. You'd look for, because if you have a heart attack, you're actually damaging the cells. And it was kind of interesting too, because I found out about this when I was hit by a car. And I thought it was kind of cool, because here I'm laying in the emergency room and they said, yeah, you bruised your liver and bruised your heart. I said, yeah, the heart was in 4th grade. No, No cardiac humor? Okay. No, but how do they find out? I thought, oh my God, these guys are like magical. What they're doing is each organ system that you have has certain cells, and those cells have certain enzymes that pertain to that organ, and if you break open the cells, you get certain readings in the bloodstream. Isn't that cool? I thought it was really cool. The new definition, because those three criteria were obviously too complicated. The new definitions for, they threw out the alterations in the ECG, and all the blood indicators were gone, and so now it was down to troponin. Okay, this is one thing they're looking for. So, Doc, I had a little chest pain, okay, last night. Oh, let's check you. Are they going to look for the ECG? No, they're just going to look for one blood value troponin. Okay, now, so what this is called is an NSTEMI. N stands for non. STE is part of the ECG that they would see in there. MI stands for myocardial infarction or heart attack. So we're looking for an STEMI. Okay, now this is the thing that you'd see on a chart. So this means that the person had a high level of troponin and some type of chest pain or something. So this means immediately, it could be before the heart attack's developing. So it gives us like approval to go in there and do some advanced studies.
Wow.
No, not wow. Ka-ching. Okay, because now, again, are you asking about lifestyle factors? Are there anything else that could raise troponin levels? So when you look at this, what the troponin is, okay, it's released into the bloodstream during a heart attack. Okay, so that is an indicator. But it's also released if you have chest pain. It's also released if you were drinking alcohol and you had excitement. It's under normally daily activity. It could just be released in there. So there's not like a deep history of, wow, were you watching the Super Bowl and you happen to be, wait, it wasn't the Jets. Who's that team from north of Oregon? Seattle. No, I'm kidding because my partner, he liked Seattle and he was depressed. Okay, so his troponin levels were really high. Okay, they were. Okay, so now, but remember, you wiped out those three criteria. You got somebody with chest pain and high troponin levels. That's it, man. What we got to do is do a stress test. If you have any type of knee or foot or hip issues, we're going to do a chemical stress test. We're going to sit you in a chair. We're going to put some chemicals in there to stimulate your heart to elevate it. Now, when it's stimulated with these chemicals, then we're going to put some dye in there. Then we're going to take a picture of it. Okay, now if we see something, okay, then, oh my gosh, you're so lucky you had one artery that was 80, 90%, whatever occluded. Now we got to do a stent and angioplasty, and then we're going to put you on some blood thinners, we're going to put you on some blood pressure drugs, we're going to put you on this. You were so lucky you made it in. That football game could have killed you. Okay, but when you look at it, it's all designed to promote the catheterization. They're not going to look at any other factor. Okay, and so what is this doing? This is doing 1 in 3, so look to the left or look to the right. In a standard population, not this educated group, okay, one of you guys would have a heart problem, okay, and it'd be diagnosed this way. So when we look at it, 2003, the Mayo Clinic did a study, okay, on the two main catheterization procedures. Remember, you got an artery that showed not completely clear on their test, which the test is bogus to begin with. And so you put a balloon in there and expand it up, or you put a stent in there and force it open. Now the stent is a wire cage. Now what I want you to appreciate is the lining of the artery, the lumen. This is the clogs, or the what they'll see on an angiogram isn't floating around on the surface. It's actually underneath a layer of tissue called the endothelium. So it's not a hunk waiting to break off. So if you have an artery that's like this, that has a small elevation in the lumen, okay, which is a rise in that from some type of tissue damage, then you go in there and push this open with a wire cage, it's going to put pressure on the walls. Does that make sense? Okay, this is why, I mean, just for fun, if you're just sitting around, type in stents and lawsuit, okay, and you're going to see a huge amount. Now, they know that the stents are causing a tremendous amount of problems. So what they're doing now is called stent retrievals. Okay, which is kind of neat because you're not going to have one area on one artery that's clogged. Does that make sense that you have miles and miles and miles of artery? Why would just the coronary arteries be affected? No, they're not. You got to look at the problem as systemic. So when we look at this, what they say, the ballooning in stents, it does reduce complaints. Now there could be a placebo effect in there. It could be because it's restoring the nerve supply to it, or it could be because of all the other medications that they put on there to change the function of it. And I'm going to show you why some of the medications will actually change the symptoms. Put you at greater risk of a heart attack, but it does change the symptoms. What they did find out is that it doesn't prevent heart attack, it doesn't prolong life, and it doesn't reduce the frequency of heart attacks or death. Bummer, I thought that's what it was for. Okay, and also they warned that flattening out the plaques in the vessel walls, which makes sense because if you've got a plaque here and you're expanding this out and you're pushing that down against it, it could lead to bleeding. That's why when they're doing the catheter procedures, they got the crash cart there. Small lumps can become detached and float in the bloodstream. This is why they had a problem putting the wire cages in first. Then they medicated the stents, and that was even worse because they would clump blood cells together, and this would cause more strokes and everything else. And it's weird. Would we be doing this on an antelope? Okay, remember, we're an animal species. We don't have a problem. There's something wrong. This one, New England Journal of Medicine. Stents cause higher death rates. And you're starting to think, well, wait a second. We found out that the diagnostic procedures of injecting dye in the heart identifies possibly a heart clog, but now we know there's always secondary blood supply. So putting a wire cage in the heart to force that open, it causes higher death rates. And you start looking at this, wait a second, do you see the problem with the logic here? If you're forcing that artery open and it really is the problem, you should be showing lower death rates. I'm just connecting the dots here, right? It shouldn't be that complicated. Okay? The higher mortality rate and decrease in blood flow makes it necessary for additional research to be conducted before routine stenting can be recommended as a standard of care. No kidding, but is it the standard of care now? Yeah, it is. Okay, the study also offers no evidence that routine stent placement after a heart attack will reduce future complications such as stroke or another heart attack. So the procedures are not working. Now, here's another one. The Journal of the American College of Cardiology, 2003, a 7-year-long study. Now, what they did is they checked people that had stents. Evaluation of use of catheterization in chronic stages of heart disease. Okay. Now, precisely shows the uselessness and potential damage that can be caused by the intervention in chronic heart disease. Although catheterizations and stents have been claimed to be life-saving measures, they do not prevent heart attacks or save lives. This intervention is accompanied by a great placebo effect. So they're saying, oh my gosh, if you're getting any results, it more than likely isn't from the wire cage we just shoved in your artery in your heart. It may be because we told you you're going to get better. Okay, a 5-year one, again, out of the Journal of the American College of Cardiology. Now, this one here is called INCTUS, Invasive versus Conservative Treatment in Unstable Coronary Syndromes. Okay, I know, okay, I was reading, okay, when you're reading a journal article, you always get the first page, and what it has is the hypothesis, the outcomes, the methods, okay, and the conclusions. And I'm reading this to my partners, and I'm saying, guys, this ain't in English, okay? Because I gotta translate it into the average person that doesn't know what, because how it's actually worded is bizarre. So what I did is I shortened the conclusions to just get the highlights. We could not demonstrate a long-term benefit of the early invasive strategy in reducing death or myocardial infarction. Invasive versus conservative treatment in unstable coronary syndromes. And so what they're saying is we're trying to do it. We have this. We're doing these procedures, and we're not showing a benefit. Now, if anyone's gone to a cardiologist and anyone had an angiogram and anyone's been diagnosed with a clogged artery and told to get a bypass or a stent or a balloon, are they aware of these studies? So what's causing the chest pain? What's causing the heart attacks? What's causing the heart disease? Because obviously it's not the clogged arteries. Okay, does that make sense? Inquiring minds want to know. Well, here's another study. It shows that heart bypasses, and I love this because it's literally, your heart is defective. Now, I look at human beings that their body repairs. Okay, their body regenerates tissue. Your self-repairing, self-healing mechanism. Okay, I mean, that's not some weirdo hippie thing. That's an actual anatomical fact. So if there's a part of you that's broken, doesn't it mean that maybe there's nerve supply or blood supply or something that you're missing, some type of deficiency or toxicity? And so when we try and second guess your body, well, we're going to take a vein out of your leg, we're going to go in here, we're going to wrap around the clog. Yeah, okay, so, there's a lot more arteries than just the coronary arteries. Maybe there might be more clogged arteries, but we're not going to check for those. We're just going to wrap it around the heart. So we're not going to look at genetic expression. We're not going to look at systemic inflammatory problems. We're not going to look at what is actually causing that. We're not going to look at the environmental factors, the genetically modified foods, the toxic diet, the lack of hydration, the clumping together of the bloods, the nervous system, the sympathetic or parasympathetic. We're not going to look at any other causes, okay? It's just this basic, simple, antiquated idea that it's a clogged artery. Now, I want to go back to this. We've known this since the 70s, that 20% of the people with heart attacks had sufficient enough clogged, but they didn't show it. In 2004, that was 10 or 11 years ago, only 41%. I mean, keep holding this. So what's the cause of the heart attacks? Why are we getting so many? Do you want to know? Okay. I know, it took me all that time to say it's not a clogged artery. Okay, guess what comments I'm going to get? Yes, it is a clogged artery. My cardiologist said so. Okay, let's look at the nerves. Because do heart attacks happen slow or fast?
Fast.
Yes. Do clogged arteries happen slow or fast?
Slow.
Just checking. Okay, so what we're looking at... It's kind of cool. If you had those, like this gauge, okay, the common sense meter in this group, bam, baby. Okay, so when you're looking at this, okay, let's look at the autonomic nervous system. You got two types of nervous system. You got sympathetic and parasympathetic. Sympathetic's fight or flight. This is initiated under short bursts. Okay, like anybody have a bed magnet at home? Oh, come on. This morning, you were in bed. It was cold outside. You had the blanket on. And it's like, I don't want to get up. Okay? That's what I mean by bed magnet. Okay? In order to get out of bed, you had to have the sympathetic nervous system. Okay? So you don't need to be chased by a tiger. It's just like, oh my word, I got to get up. Okay? The parasympathetic is also called the rest, digest, and repair mode. Now, both of these has strengths. They have power to them. Okay, so it's not like one's on and one's off. There's an energy level to them to allow them to adapt to environmental stimulus. Okay? Now, expose your hand just like this. Okay, I'm going to blow on it. Did you feel that? Okay, now, I just put out a force of energy that wasn't enough to cause her to feel it. Okay, try it one more time. Okay, good. I put out enough force that was able. So that was a demonstration to show you that you can have a stimulus but it not be forceful enough. So what I'm going to propose to you is that the cause of heart attacks is an imbalance in the system and a decreased parasympathetic nerve supply. Now, let's do a little anatomy and physiology. I know. This is so cool because you're going to see light bulbs come on. Okay, let's look at and this is actually out of the heart rate variability in patients with diabetes mellitus, ischemic heart disease, and congestive heart failure. That's the title of the article. Anybody want to read it? I know. Okay, it's really fun actually. It's the Journal of Electrocardio. Now let's look at the two different neurotransmitters, or let's look at how they communicate. Okay, the parasympathetic and sympathetic nervous system, are they electrical, chemical, or both? Say both. Okay, good. You're right, they are. Okay, now they also have a thing in the adrenal gland. Remember, we always call the adrenals the pharmacy of the body? Well, the parasympathetic has a part of the adrenals, and the sympathetic has a part of the adrenals. The parasympathetic makes three main chemicals, okay, to communicate their parasympathetic activity. Remember, they're the rest, digest, and repair modes, okay? So if you have that, the parasympathetic is going to send it. Now, you got the parasympathetic, it's also called craniosacral. So you've got stimulates or sensors, and the nerves actually originate in the skull, in the brainstem, and the sacrum. That's the parasympathetic. And so it's also called the craniosacral. The sympathetic is also called the thoracolumbar. So you actually have nerve sensors, and the sympathetic nerve supply, or the sympathetic nervous system, is in that area, okay? So these areas are the actual areas of the parasympathetic and actual areas of the sympathetic. I could take you through a human dissection, and I can actually show it to you. I could have you hold the parasympathetic nerves. I could have you hold the brainstem in a cadaver. So this isn't any esoteric thing. Now, these have actual connections to the adrenals, and that is the pharmacy of the body. The parasympathetic makes acetylcholine, nitrous oxide, and cyclic guanosine monophosphate, or CGMP, ACH, and NO. Now, that's the main neurotransmitters that it makes in order to communicate, okay, and its chemical processes to communicate its message. When we look at the sympathetic, this is in the middle of the adrenals, okay, and it produces mainly adrenaline, okay, and there's also some other ones, noradrenaline, and a couple of others. But that's mainly its communication pathway. Now, under the sympathetic, it also is for fight or flight. So do you think you need more energy if you're running away from something, or if you're preparing for battle? So it also does what's called glycolysis, where it breaks glycogen down to glucose. So it actually helps increase the blood glucose in the body. Okay, now I know this gets kind of complicated, but when you look at it, we're going to look at the adrenals connection to the sympathetic and parasympathetic. Okay, and I know this is like, oh God, I had anatomy. Please don't make it any more complicated. Just understand that the parasympathetic nervous system, which is in the brainstem and the sacrum, and the sympathetic is in the rib cage area in the top of the lumbar, they both communicate to the adrenals, which is the pharmacy of the body. The parasympathetic makes three different things: nitrous oxide, acetylcholine, and CGMP, and the sympathetic causes glycogen to be broken down, or elevations in blood sugar, and it also causes adrenaline to be formed. Okay? Okay, now, heart rate variability. This is one of the tests we do at our office. Okay, what this does is it checks the balance of the nervous systems. Not just the balance, but also the strength of them. So when we're going back on that demonstration, you do have sympathetic and parasympathetic, but how effective are they at responding to the environment? Okay? Because if your body is not going to respond under stress, you're going to die. If your body is not going to respond when you need to be resting and digesting and repairing, your body is going to be breaking down before it builds up. Okay, does that make sense? Thanks, Doc, for helping me with that. I was trying to, I'm explaining and I'm beating my desk and I'm going, oh my gosh. Yeah, he helped me a lot. Okay, so heart rate variability studies. We're talking people with ischemic heart disease. They have decreased parasympathetic activity. That means their parasympathetic activity is decreased, and this is something measurable, predictable, and accurate. Heart attacks, do they happen slow or fast? Clogs, do they happen slow or fast? Slow. Okay, good. So we're knowing now that the studies since the 70s have shown that it's not clogged arteries that's causing it. Now we know that we have studies that show that it's an imbalance in the nervous system, and specifically it's actually a decrease in the parasympathetic nervous system. Now this is a theory. It's not going to be brought out in the public until the grassroots changes. Because if this was true, where would you go to get your nervous system checked? Not to a neurologist, you go to a corrective chiropractor. Okay, and so this means every cardiologist on the planet will have the equipment we have. They'll check your variations in heart rate. They'll check the QRS interval for 5 minutes, and they'll tell you, yeah, you're sympathetic dominant, you're parasympathetic dominant, or by God, you're right on. We're not skilled in correcting this. You need to go directly to the chiropractor, get your nervous system checked, come back, we'll change the parasympathetic nervous system. Okay. The worst ischemia, and this is lack of oxygen to the heart. Remember, ischemia comes from low supply, low parasympathetic activity, not loss of blood in most of the cases, because that's what we're finding on autopsy. So it turns out that the low parasympathetic activity is actually causing lack of blood flow to the heart, not the clogged. 80% of ischemic events are preceded by a drastic reduction in parasympathetic activity. So this means most heart attacks, 80%, are preceded by lower parasympathetic activity. And this is all build up for what we got coming up. Okay, so that's the anatomy and physiology portion. The parasympathetic nerves to the heart. We've got a sensor in the middle of the neck that's controlled by glossopharyngeal nerve. Now, we've talked about this before. You've got a heart here. It sends blood supply up. It splits. The carotid splits into internal and external. At this junction here, you got two sensors. You got one that senses carbon dioxide, one that senses blood pressure. So if carbon dioxide levels are up, that cranial nerve 9, okay, or the parasympathetic nerve that governs that, is going to send a signal down to the heart. So wow, so does that mean that even though the parasympathetic nerves are up here, it has a nerve that comes down here that controls the heart? It does, it does. This is totally cool. Now, you've got another one, cranial nerve 10, it's called the vagus nerve. No, not baby! Okay. It's V-A-G-U-S, okay. Okay. Sorry, there's some people that are going, oh yeah, baby, I want that nerve. Okay, it leads the brainstem and surrounds the esophagus, the food tube, and it's so cool when you see it because it goes on the front and back side of the esophagus, and then it branches off and it supplies the entire gastrointestinal tract, supplies the heart. Now, what's interesting when you look at this, persistent decrease in sympathetic leads to heart attacks. Decrease in the parasympathetic nervous system also corresponds with acetylcholine, nitrous oxide, and cGMP. And this is out, again, the Journal of Electrocardiology. And you start thinking, wait a second, so these guys are checking heart attacks, and they're finding an absolute alteration in the nerve supply to the heart, specifically decrease in parasympathetic activity. Does that make sense so far? Okay, good. So, why do women have less heart attacks on average? Because they have a high vagal activity. They have a high cranial nerve 10 activity. Why? We don't know. Possibly because they have to regenerate menses every 28 days, which is the build-up mechanism. Maybe because they can form a human. Okay, there's some difference there. Maybe estrogen and progesterone has some type of effect. But when you look at it, women and men. Men generally die around 74 with a heart disease. Women go to 80. When we're talking about heart disease under 75, about 41% of males, 21% of females. So we're talking nearly a doubling of the rates. And so could it be that since women have a high vagal activity or high cranial nerve 10 activity, that this is having a protective mechanism? Or because they have a higher parasympathetic activity? We don't know. So now what type of activities would actually lower parasympathetic activity? So what causes heart attacks? An alteration of the autonomic nervous system, specifically lowered parasympathetic activity. Okay? Can you imagine the torturous hell of listening to my radio program this morning when I was saying like this? It was driving me crazy because I wanted to explain it, but I needed pictures. Okay. Seriously, okay, now the stuff that lowers parasympathetic activity, high blood pressure. Now, why would high blood pressure lower parasympathetic activity? What causes an elevation in blood pressure? The fight or flight or the rest and digest? Fight or flight. So if you have a clogged artery, the body's going to have to elevate blood pressure in order to get by that. If you have any stress, physical, chemical, or emotional stress, the sympathetics are going to be fired. So high blood pressure is not a disease. It's an adaptation using the sympathetics. If the sympathetics are firing off, what's low? Parasympathetics. What's the cause of heart attacks? Lowered parasympathetic activity. So that makes sense. Smoking. Smoking causes constriction of the arteries, but it also stimulates what? The fight or flight. Okay, so diabetes. Now, let me see, diabetes. Which of those nervous systems, the parasympathetic or sympathetic, had glycolysis? Which one elevated the blood sugar? Which one broke glycogen down to glucose? Sympathetics. Now, if the sympathetics are activated, what happens to the parasympathetics? It drops down. Oh my gosh. So that makes sense why these activities would cause a lowering of the parasympathetic. Is that why when they talk about risk factors, the high blood pressure, smoking, diabetes, and stress, so that it's not the clogged arteries. Because high blood pressure isn't going to clog arteries. Okay. Smoking might damage arteries. Okay. And we know diabetes doesn't clog arteries, but it does thicken up the blood. So can you see the correlation here? Oh my gosh, I think we're onto something. So when we look at this, this is actually what a cadaver sample looks like, where the junction, where that parasympathetic is. So now thinking of that, so now we've got a sensor that controls the heart that's here. We've got a sensor that controls the heart that's here. Does that mean that perhaps if you have an alteration in neck position, that's going to pull the spinal cord and possibly alter parasympathetic activity? Boy, will it ever. Okay, so now let's look at the other thing. Remember the three chemicals that the parasympathetic nervous system made: nitric oxide, NO, acetylcholine, ACH, okay, and CGMP. I'm not going to do the whole CGMP is a big word. Okay, nitrates stimulate nitric oxide production. So this means that the parasympathetic is not going to call down to the adrenals if it's available. Does that make sense? Mm-hmm. So you're going to decrease parasympathetic nerve supply by having more nitric oxide present. Okay? Now, what's in nitrates? Yes, they do use it in certain medications, but it's also in processed foods. Are heart attacks higher in people that eat more processed foods? Absolutely they are, but not because it does damage arteries, but could it be from the nitrates elevating the nitric oxide? Wow. Okay, now aspirin and statin drugs stimulate production of nitric oxide and acetylcholine. Wow. So does that mean if somebody was prescribed an aspirin a day, okay, which is completely insane, I'm going to show you the studies, but if they're also taking a drug to lower cholesterol, that's actually leading, because there's always a rebound effect, to lower parasympathetic activity. Does that mean, and this is huge because this is our handout. Oh, whoops, I thought they were going to be stapled. On this one here, it says over 1 million people a year in the U.S. die of heart attacks. Are they dying in the U.S. because they don't get enough drugs or surgery? I hope people on YouTube can hear there's an audience that's giggling. Okay? No, because that's foolish. In this, do they need more drugs and more surgery faster? Do we need more pharmaceutical outlets? Okay? No. We're barking up the wrong tree there. So what happens is, if you take a drug that forces the production of the neurotransmitters used by the parasympathetic nervous system, when those things go out of your system, it takes a while for the parasympathetic to kick up. Since those neurotransmitters aren't utilized, that's going to simulate a lower parasympathetic activity. Does that make sense? So does that mean that nitrates, aspirin, statin drugs, beta blockers, that all of those are going to lower sympathetic or parasympathetic activity? And what's the cause of heart attacks? Lower parasympathetic activity. Okay. Here's one of the definitive studies on aspirin. Okay, so if somebody says, yeah, take an aspirin a day for a healthy heart, well, you can say definitively, if you take an aspirin, you're per 100,000 people, this means 100,000 people take an aspirin a day, you're going to save about 33 lives. Okay, that means 99,970 some, okay, 64 or 67 are going to have no effect whatsoever. However, out of those, you're going to have a 37%, or about 100 people will die of gastrointestinal bleeding, and about 10 people will die of a hemorrhagic stroke. So we're going to lose about 110 people and we'll save about 35. Anyone good at math? Okay, now aspirin is supposed to be what? A blood thickener or a blood thinner? Okay, water is a good blood thinner. Okay, vegetable juice is a good blood thinner, and those don't have an increased risk of stroke or gastrointestinal bleeding. So are there better ways to help your blood? Yes or yes? Yes. Okay, good. Oh, wait here. I gotta show you this. This is one of the guys that did the study. clear that there is an incredibly fine balance between the possible benefits and risk of intervention. We need to be extremely careful about over-promoting aspirin intervention without having first fully understood the negative side effects. No kidding. That should be emblazoned. Every medical doctor should have a tattoo of that on their forearm before they reach for the prescription pad. I don't think that's, I mean, if they're going to force people to get a flu shot, I think we should force people to get a tattoo. Okay, now this is a patient that came in a couple of weeks ago, 37-year-old gal. What you're seeing here, this is her heart rate variability study. She came in with carpal tunnel syndrome, numbness in her hands. Now we know that's a double crush injury. She's a nurse. Why do you want to take a picture of my neck? Well, that's where the nerves that supply the hand come out of. Okay, and so sure enough, her parasympathetic activity, that's on the right-hand side, is incredibly low. She's a heart attack waiting to happen. When we go take a look, she's got massive forward head carriage, absolutely no curve in the neck. That's pulling the spinal cord down, altering her parasympathetic activity. And what's neat is she's a nurse. She gets the big picture. This right here, this is how you gauge your risk. At 37, she's probably not going to have a heart attack. But if this remains there at 40, at 50, at 60, okay, what's going to happen? I mean, it's guaranteed. You know, now when we look at this patient, this is a patient currently, and she's frustrated. Okay, that's not her real name, but this right here, you're looking at a massive structural deviation, so that means she's probably in a sympathetic dominant state for years. That means her parasympathetic is down. These wires in the front means that she did have a stress test. They diagnosed a clogged artery, so they split her sternum, opened it up, took a vein out of her leg, went around the heart, closed the chest back up, wired it back up, woke her up, okay, and what do the studies say about a bypass surgery like that? Does it prolong life? No. Does it prevent heart attacks? No. Okay, and the intervention actually does more harm. Luckily, she came in because, my gosh, that's an alteration in the nervous system, and that's for sure an alteration in the curves, and this has been a problem there for years. Now, what's neat is we're going to be adjusting her. We're going to restore the nerve supply. How fast do you think she's going to get a response to having decreased chest pain and decreased the stress? Because she doesn't want to go in and pop her chest again. It's amazing because it's almost immediate that people start to notice that they can move their neck better, they can breathe better, they can sleep better, they can go to the restroom better. All that is we're just balancing out the nervous system. I mean, just balance it. Oh, by the way, in order for her to be diagnosed with this, because she does have a knee issue, before they did the open heart surgery, and I think it was done like about 8 years ago, so this way she's in the mid-60s, they put her in a chair, injected her with chemicals, her body was shaking, then they injected dye, and then they found out that she might have had a clogged artery, and using that old theory, they did the bypass and everything else. I mean, this is 2015. It's time that we say the emperor has no clothes. Okay, it really is. It really is. I mean, the American Heart Association, if you want the worst advice ever, okay, I mean, the worst advice, they're saying liquid vegetable oils like canola, safflower oil, sunflower oil, soybean oil, and olive oil. They advise egg whites instead of eggs, which doesn't make any sense whatsoever. The corn safflower oil, they have a 77-to-1, 60-to-1 ratio, omega-3 to 6 ratios. Disease starts at 8-to-1. Okay, so they're recommending, they're recommending heart attack containing foods, okay, to protect. It's just the disconnect here is so far and so great. The salt. How many cardiologists are going to say salt should be reduced? Well, it turns out, okay, and this is again, there's some brilliant MDs out there. This was August 2014. Time to shake the sodium guidelines. See, the American Heart Association is saying reduce salt, reduce salt, reduce salt. What they're seeing now in assisted living centers is a massive heart attack problem from hyponatremia. This means they're not getting enough salt. Okay? No, seriously. Okay, but wait a second, okay? The red line is where they say you should have, that's where the salt is. It turns out the more salt you get, you're going up this line, the less heart attack and deaths you have. So it turns out that taking in about 4 times the amount of salt that the American Heart Association recommends, you have about half of the death rate. Okay, now these statistics are known. Okay, now I love this one. And this is Dr. Topol's message. The American Heart Association, however, isn't backing off from the 1.5 sodium guideline. But I think there's a big lesson to be learned here about guidelines without adequate evidence. I like this guy. They can do harm. Hopefully this lesson will prove to be impactful, because that certainly has not been the case to date, as in cholesterol guidelines, okay, blood pressure guidelines, PSA or prostate-specific antigen guidelines, mammography guidelines, and a very long list of poorly conceived and non-anchored guidelines. That means non-anchored in scientific basis, okay? Isn't it about time to recognize that there shouldn't be rules for populations? I love this guy. Okay, some people are exquisitely sensitive to salt intake, while others are remarkably resistant. Average is over. Wow. Oh my gosh, common sense. This is the future. I mean, you guys should have goosebumps now. I mean, people are actually thinking about what's going on. When we look at this, high blood pressure is not a disease. It's an adaptation to toxicity. When you see what healthy blood looks like, when you see what unhealthy blood looks like, our diet, I mean, we should actually be storming, not the pharmaceutical industry, not the CVS pharmacies or anything. We should be going in to the supermarkets and taking the toxic oils off the shelf, because we know the polyunsaturated fats are killing our population. It's causing less oxygen to get there. If you have unhealthy blood, the blood pressure and the stress rates are going to increase. If the stress rates increase, that stimulates the sympathetic activity. What's the cause of heart attacks? Lower parasympathetic activity. So can you see that these clear oils, the canola oil, the polyunsaturated fats, the safflower oil, I mean, it's nuts. We just got to stop it. Non-steroidal anti-inflammatories cause 20% of all heart failures and the cause of high blood pressure. Now, this is the Annal of Internal Medicine. How many doctors out there are saying, oh, honey, you got joint pain? Here, take this ibuprofen. And I'm going, wait a second, you're giving her a chemical that can damage her heart, it's destroying her joint cartilage, and it's to make her comfortable temporarily? Okay, read the Hippocratic Oath and fire yourself. Okay, remember, the doctors work for you. If your doctor is recommending a toxic therapy, okay, that destroys your body, fire him. Okay, if he's in your group and he's a nice person, then educate him. Give him the guidelines on the heart. Okay, give him the guidelines, the new guidelines on the parasympathetic. It's only been around since the 70s. Okay, give him okay, help them, because they're in groups that are not helping us. And I tell patients all the time, what kills more people, medical doctors or guns? But then we got these brilliant guys like Dr. Topol. We got this brilliant doc here. These guys get the big picture. They realize that the body's smart. Do you see that? So it's the system that we got to change, because there are brilliant docs that get the big picture. There really are. I mean, sudden death after radiofrequency ablation. Okay, does anyone not know what ablation is? Okay, imagine you got a heart, and you think an area of the heart isn't functioning right. It's like contracting at a different rate. Wait a second. What controls cardiac contraction? Is it, it's the nervous system. Okay, well, here's a thought. Let's take some wires in there and burn those cells. That's called ablation. So we're actually going to kill portions of the heart. Okay, but don't worry. We'll have a crash cart available. This one says, out of the Journal of the American College of Cardiology, that sudden death is likely or possible related to a catheter ablation occurred in 2%, but the risk of sudden death is highest within 2 days after the procedure. Okay, yeah, we're going to second guess the intelligence of the heart. We're just going to burn part of it. You'll be just fine. This is honest to goodness what you need to protect yourself from a heart attack. You need to get your nervous system checked. Honest to goodness, it's that simple. You need to get x-rays and a heart rate variabilities test. Okay, we do a little bit more advanced, but can you see that the nervous system is the source? Yes or yes? Okay, good. You have to get regular exercise. This is just a move. I mean, I've got patients that are quadriplegics. We've got patients missing limbs. Okay, we've got patients that are Lou Gehrig's that are wheelchair bound. They're exercising. They may only be doing leg swings. They may only have their spouse moving their legs like this, but by gosh, any type of movement is going to stimulate the nervous system and get more sensory input into the brain. Proper nutrition. This means whatever the American Heart Association, do the opposite. Okay? You want some more bad advice, go to the American Diabetic Association. Okay? They're still recommending aspartame, for God's sake. Okay? So you know, if man makes it, you don't eat it. Okay? If Satan is involved in it, you don't buy it. Okay? Sufficient rest. This means deep sleep every night. And honest to goodness, if you can't sleep, what do you got? You got an imbalance of the nervous system. You're probably sympathetics are firing off. You're ready for a heart attack. And it takes about 5 days to solve the worst insomnia ever. Okay, there was a brilliant study out of Glasgow, Scotland. And check our tape on that. And then prayer and meditation. Every study, when you're in prayer and meditation, what do you think happens to the parasympathetic nervous system? Elevates. And that's tissue repair. Every study. If you're praying for yourself, it increases. Every study I've seen that if a group are praying for somebody else, their tissue increases. Wow. But that would be a cool study. Okay, and here too, as weird as this sounds, if you're taking a blood thinner, the doctors that are prescribing blood thinners will say, goodness gracious, stay away from dark green leafy vegetables. Okay, I know it sounds insane, but they're going to say that the dark green leafy vegetables have vitamin K, and vitamin K is involved in blood clotting. Okay, it has nothing. Blood clots in response to tissue damage. It doesn't clot in the arteries. It clumps in the arteries. So this is a way to explain that vitamin K in green vegetables won't clot the blood in my arteries. Okay? Now, back away from that kale. There should be a cardiac warning on there. Okay, does that sound as stupid to me as it does to her? Okay, good. Yeah, so this is a way to communicate to the doctors that are giving blood thinners. So if you happen to have a stent or an angioplasty or a bypass surgery and they tell you to stay away from green vegetables, give this to them. Okay, so that way you can start eating healthy stuff. Now, all of this research, okay, is available on Owner's Dash Guide. Please look into it. Please share it with your local cardiologist. It's going to hurt. It's going to hurt their head because you're absolutely changing the paradigm. It's like talking vaccinations to people that think it's a belief, you know, it's the savior of our world. Okay, so just talk to them slow. Use actual science. Have them give you data on their point of view, and let's do it with science. Let's not like beat each other up. So use this and save lives. And and then Heidi is in the back. This is one of the tests that we do. We do a heart rate variability test. Okay. We also do surface electromyography. We also do a rolling thermal scan. We also do digital x-rays. With those, that I found is the most thorough assessment of the nervous system. A chiropractor is a nerve doctor. I'm not a muscle doctor. I'm not a bone doctor. I'm a nerve specialist. Okay? And to get checked, and this doesn't matter if you're from England, Texas, Arizona, Oregon, Australia. Okay, so, but that's this group. Okay, so thank you very much. Okay, now.